Hey guys, what's going on? My name is Dr. Colin Zhu, and thank you so much for being here with us. This is the Thrive Bites podcast, and welcome to season 5. Here we talk about 3 things: plant-powered living, enhancing emotional resilience, and creating a thriving mindset. And I interview the most passionate guests here, ranging from physicians to coaches to dietitians to entrepreneurs. And my hope is to give you really informative and high-valued conversations. So please follow us here on YouTube, Spotify, Apple, and wherever you hear your podcasts. Come on in, and I can't wait to see you inside. So hi, everyone. This is Dr. Colin Zhu, aka the Chef Doc, and welcome to another episode of Thrive Bites podcast. And we are on location in Davis, right?
That's right.
The proper city is Davis, not West Sacramento, right?
Correct. We're in Davis.
Okay, excellent. And I am joined by my lovely friend and colleague, Dr. Francis Southwick. Thank you so much for inviting us, me and the podcast, into your home.
It's my pleasure. I'm so happy that we found each other.
Yes.
Yeah.
After many, many years.
That's right. Yes.
So just to orient not the office, but our audience is, we first knew and met and worked with each other from the great old town city of Lewisburg, West Virginia, where we went to school, we trained, and we became fellow graduate teaching assistants, is the proper term. But I think it's also called pre-doctoral fellows as well, in the Department of Osteopathic Principles and Philosophies. And we're going to dive deeper into osteopathic medicine in a moment. But first, I want to introduce to our audience who you are. And I just have a little blurb. Dr. Southwick is a full-time osteopathic physician, and she's also a literary nonfiction author. They currently practice in California's Central Valley, and as an osteopathic physician, they offer strength-based, trauma-informed osteopathic care, including OMT, or otherwise known as osteopathic manipulative treatment, also providing gender-affirming care and medical care for the queer community. And she's also the author of Prognosis Poor in 2015 that came out, and just recently Prognosis Fair that came out in 2021. So again, thank you so much for having me, and thank you so much for being on the with today.
My pleasure. Thank you for inviting me. I'm happy to be here in my house with you.
Happy to be here, in your own home.
Yes.
It's so good. It's so good to be in my own home. It's great. You and I share so many fond memories, and the bulk of the interview is going to be talking about what you do, your current work as a physician, and also your latest book, Prognosis Fair. But just to kind of back up and kind of help orient, we are both, DOs, and I want to, whenever I get a doctor of osteopathy or doctor of osteopathic medicine, on the show, I definitely want to continue to re-emphasize what that is for our audience members. So, so why don't you help? I want you to be able to help define what osteopathic medicine is, and what brought you to first study it.
Absolutely. So, so I've always wanted to be a physician, one of those, diehards from age 4 kind of thing. And I learned more about what a DO is because my uncle became a DO in his later life. He was a toothpaste salesman.
What?
And then he decided, no, I'm gonna do more. And so he became a physician by becoming a DO. And so that was my introduction. I learned more about what a DO is, especially related to OMT. I've always been kind of a tactile person, I would say. I communicate best with people through touch. And so that's what OMT is, right? It's listening with our hands, treating people, patients, clients with our hands, and it's a beautiful way to practice because it's open. I feel like it's open-ended. I don't feel trapped into boxes related to medicine. I can offer prescriptions when needed, but I can also discuss lifestyle changes really easily, practice OMT, help with addiction, help with all kinds of. It's very wide. Is how I would describe it. Very wide, open-ended.
Nice. Yeah, so I like the fact that you've mentioned open-ended because the way I picture OMM it's always like water. It's very fluid. It can go in so many different directions depending on the patient and what they come in through your doors for. And I love the fact that it integrates emotional, mental, spiritual, in addition to, the body physical. For me, growing up, having my mother as a Chinese medical doctor, she, already instilled in me, all this already. And so when I came upon osteopathy, I was like, wow, how come no one, told me about this? I only discovered it like the third year of my college, of my university. And I was like, this is the only thing I'm going to apply for, and I did. So
right,
yeah,
it's a beautiful way to practice. It's a beautiful way to have one-on-one interactions with other people, where we have a wonderful skill set and toolbox to be able to offer help in so many different ways.
Yeah. I think in addition to our allopathic counterparts, we receive 300 hours. And of manual manipulation, and I like the fact you akined it to Reiki as light as Reiki, but as hard, quote unquote, as chiropractic, which a lot more people can relate to. And I think massage therapy is like in between, in terms of the spectrum, I would say. But it's great, find an osteopathic provider and go see them.
Yes.
I think our professors from West Virginia will be so proud.
Yes.
So a question after that is, how does the principles and philosophies continue to echo into your current practice? Which how does it echo?
Probably the most concrete way is I have 4 hours of my practice every week dedicated to only osteopathic evaluation, and the expectation is no labs, no meds, only evaluation and hands-on treatment as indicated. I've kind of been able to carve out time, even though I was the first DO to work at my office. They kind of went out on a limb and said, okay, I guess you can do your OMT
really? That's
stuff.
awesome. Wow.
And now, I get so many consults from my partners. It's such a great collaboration. We trade patients back and forth, ask for help. So that's the most concrete way. But I would also say that it's just embedded in all of my interviews, all of my decision making. Thinking about, this sounds cliche, but a whole person, right? A holistic approach. What environment is this person in? What is their background? What's informing the decisions that they're making about their lives, rather than just focusing, sort of on minuscule numbers, but a larger picture of what somebody's life is.
I definitely resonate with that because I'm a very bird's eye view, macroscopic, type of person. And if I can't see the whole picture, then it's a lot more challenging for me to, because I'm a connector. I like connecting the dots. And, in order for me to do that, I gotta see the macroscopic view. So, and I think, part of, I know Dr. Lumley would be, proud of us because he always talks about the fascia and how everything's like you push something over here and you feel it over there. And I'm like, wow.
Yes.
And I love that. And, on a more broad point of view, because we talk a lot on this podcast about food and how it relates to the greater whole. And now we're talking about sustainability. We're talking about, the echoing effects of all the ramifications, which we're not going to go on this this particular show, but it's huge. And as an analogy, it's similar to our bodies, how, something on your toe can be connected to your shoulder or, to your neck. And I love the fact that we can connect, and integrate those principles into our current work.
Absolutely. The ecology, the grand ecology and the microecology and how they interact, right?
Yeah.
Yeah. Beautiful.
Awesome. So the next question, we're going to be talking about this book. She is the author of Prognosis Fair, a trauma case study for clinicians. And this is actually the second book. And this got released 2021. And there's not enough words for me to put in terms of how impactful when I read through this it has been, for me. We were talking a little bit off camera about, so first of all, I guess in a very distilled, simplified, and you can correct me if I'm wrong, it's pretty much a book about trauma, essentially, right? And it's, without giving away too much, it's really through the lenses of yourself, where you're taking different episodic memories and experiences. And you did a beautiful thing where, you've also interlaced it with poems. You have a Spotify playlist, that helps people to get, into the, mood, quote unquote. There's a lot of, also a lot of great, in the back with your appendices, a lot of great, action steps, what to consider next, what to do next. Here are some, pamphlets or handouts, that you could use in your offices or give to someone else. And we can go more into that, later. Essentially, you've made it known that you've been a victim of sexual abuse, growing up, and you've been able to channel that into your current, work, also as an author. So this may be obvious, but why was this important to continue to channel this, through your current, endeavors? Like, why write a book about it? Why, integrate that into your practice? Because for someone else, similarly, that may have gone through a similar experience, could easily just put it into a box, put it away, and never either one, talk about it again, bring it up, share it, let alone share it, and, ultimately be able to integrate it into their work. Why is the question.
What a process. I would say it's such a process. I did not set out to make my experiences into a book when I started exploring my past and going into psychotherapy and just kind of trying to figure out why I feel the way I feel, why I was having, episodes of panic or suicidality, things like that. That was the beginning of the book, really, for me. Was it? These memories kind of forced themselves upon me. I got as far in my life as I could. I finished residency. I was completely financially independent and secure in my life, secure in my work. And suddenly these feelings and memory fragments started coming back, and I was really forced to deal with them. So I feel that my brain really forced the issue. And through therapy and through writing courses and things like that, it sort of tumbled out. And over a 7-year process, eventually became a book. So that's the process. And why to actually put it out as a book? The most healing thing for me with my first book was putting it out there with a lens of, here's some concrete ways that you can help yourself and try and avoid some of the pain that I experienced. Open up some insight to kind of move other people a few steps ahead, I guess. Do you know what I mean? Just to move the mile marker a little bit so that others aren't suffering quite as much.
Yeah. So number one, thank you, for sharing that. And definitely want to be, sensitive in terms of not just yourself, but everyone that's watching who may have experienced something similar or know of someone that experienced something similar. So, I think it's very important. It is very challenging. I can imagine not having, a shared experience, but I can only imagine, how much, I was saying to you, off camera, how courageous and how much strength. I think a lot of strength comes from courage and bravery to push through the insurmountable pain at times, to kind of get to the quote unquote other side, to be able to share a story, to be able to, use your pain, for purpose and to help someone else, like you said, move the mile marker, and, maybe save them some time, save them, if you could refer them to a specific person or a specific resource, they, for example, might not have to traverse a certain number of years of, pain, and that's incredible. I mean, it's so much. I definitely encourage you guys to go, take a read and pick it up. So my next question, what I love about, reading through it is that you stated a few times that psychology is neurology and neurology is psychology. The first natural question is, what do you mean, by that? And then we'll go from there.
So I noticed on my neuro rotation, on my psych rotation, that the meds that we were prescribing, a lot of them were really similar. And somehow that was my route to realize that it's all one structure that we're talking about. We're talking about the central nervous system. And, person-kind, we'll say, has artificially divided the brain up to different sort of reductionist kind of pools. So one is a neurologist, one is a psychiatrist, one is a therapist, one is a mind, body, spirit practitioner. But underneath what we're talking about is the central nervous system, the whole thing. Emotions are part of the central nervous system. It's all one thing. If you go even deeper, really, we're talking about a whole structure, a whole person, a whole experience of being a self. So I don't know how to talk about it without getting too far into the weeds there.
You had talked about neurons. You talked about you went as far as neurons. About how it was interesting because you would describe it as giving it sometimes space, giving it some time to be able to heal when you were reflecting on different trauma. And I thought that was very, very interesting because it almost gave it its own personality in a way. Like you almost treated it as a person you were talking to, and giving it its own space. And I totally agree with you how, to me, it's like it makes the most sense. And we've gotten better over time, especially with COVID and the highlight in media with mental health. To me, it just makes sense because it's like it's all under one roof. It's all under all this flesh and blood, and it doesn't make sense to separate it, but to integrate it and to spend more time to figure out the connections we have yet to, discover and, research and talk about more of the connections that we do have, that we, actually, have the knowledge base, to have. How do you feel like that has, from a clinical point of view, because we separate it, how do you feel that has, held us back in terms of potentially helping to diagnose someone, held us back from, our patients, would you say? And if we did connect it more, what could we have achieved more?
Oh my gosh. I feel like we could talk. Couldn't we just talk for days about this?
We could just talk forever. I know. But we have to
this is
distill
so
this into
Okay.
45 minutes, an hour. Okay.
Okay, we can do this. Maybe in an anecdote or something. I walked into a practice once, and a family medicine physician was making diagnoses, as we do. We collect problem lists on each patient, right? That's part of the chart. That's part of what we do. So we label people based on maybe a series of 1, 2, 20, 30 different problems that we're working on. And this particular person, I noticed a pattern of diagnosing something called borderline personality disorder. And what I noticed is that caused a sort of stigma of patients before they were even seen in the office by another provider. It labeled a person potentially misdiagnosed someone when maybe another lens to look at someone through could have been, what has this person been through, perhaps? Why is their behavior such as it is? There's so much I want to say about it.
The floor is yours. That's why we're here. Just word vomit everything out.
Okay.
But I get what you're saying, because because of the fact that we compartmentalize, it's almost like, if you ever go to the eye doctor and they're checking your prescription and they're like, oh, is number 1 good or number 2 good? So I'm visualizing what you're saying.
Okay.
And because of the fact that we've compartmentalized, we had to create so many lenses. So it's not just 1 or 2, it's like 1 to 100, probably more.
Right.
And, because we haven't, in my opinion, haven't done that great of a job in terms of, integrating, all that, we could have very well just used 1 lens instead of a bajillion, you know what I'm saying? So. That's
right. And in medicine, we often need to focus so much on pathology that it sometimes is difficult to remember to first and foremost see a person as a person. We focused a lot on that in our work at WVSOM, and then we focused a lot on that in family medicine, and medicine is evolving in that direction. A therapist I had once, I mentioned this diagnosis of borderline personality disorder that I saw coming across in another provider's practice. And I asked what she thought about it, and she said, I don't think it's a thing. I don't think it actually exists. I think it's a label that providers use when they feel activated or overwhelmed by a client or patient's behavior. And it really made me think about what labels to use for people before I apply them. Am I being reactionary? Am I being withholding? what in myself that what about me that I have not fully examined is informing what I'm seeing in someone else? That's a big part of why I continued to do this self-exploration. And it has made my patient care so much more satisfying and sustainable. Because I just so easily see people as people who have gone through a lot of things to get through the door where they're having a conversation with me. I'm able to empathize more quickly and just jump to what's important to the person sitting in front of me.
Yeah, for sure. So it's not just like, not boxes of labels or diagnoses that we put on people. They're, like you said beautifully, they're people with, these lived experiences. And how do you guide them and navigate through these sometimes could be treacherous waters, you know what I'm saying? And I totally agree in terms of the self-examination, surprisingly, and having done, my own self, work journey for like a very long time, it's so critical. It's so critical in terms of how you convey ultimately your style of practice of medicine and the way you help people, because like you said, it almost determines how you look at the other person across from you, based off of, whether you've received physical, emotional, mental trauma yourself. And, to me, it just makes you a better, physician. I'm not saying go out and go traumatize yourself, right? That's not what I'm saying. It's more about having taking the space, the time, doing the actual work to go through that examination process where, ultimately you don't see that person across from you as a box of labels, but a person with lived experiences. Yes, absolutely.
That same therapist I was speaking about just described what therapists do as, kind of act as mirrors for blind spots, which I really enjoyed that analogy as well because it's so concrete. When you're driving, you have to have mirrors at different angles behind you. You can't see, we have sort of this tunnel vision, and we can't see everything about ourselves. It doesn't always require a therapist. Therapists are really useful, but interactions with other people, introspection through whatever means that might be, is so important rather than just kind of steamrolling through life can be a bit dangerous. You can hurt yourself and other people, I think.
Yeah, for sure. Because at the end of the day, you can't, in my experience, you can't fully be in that. We'd like to say, put yourself in other people's shoes, but, no one knows the weight of their shoes except for that person, And I think when you do the self-work, you can almost get as close as possible, but you can never, put your physical, and metaphorical feet into those shoes. But you can get very, very close, but you can't, you know what I'm saying? So
it creates this humility that is such a relief that I don't have to know all of the answers. And I can just respect whoever I'm speaking with, and know my own baggage and not have it sort of clouding the interaction that I'm having with people. So, yeah, that's wow. That was a great riff we had.
Yeah. We're all about the riffs. So, what is the opposite? So if we flipped it, flip the coin around. If we don't take the time out, whether to do the self-work, if we don't take the time out to recognize the person and not a box of labels across the way, if we don't take the time out to, as much as possible, integrate into one lens as opposed to 100 lenses, what will be the ramifications of not acknowledging, of not recognizing all these different things that a person with trauma has gone through when we don't I guess, open up that space, for that? What would be the ramifications?
Hey guys, if you are interested in having a consultation with me and actually see me one-on-one, the Chef Doc Lifestyle Medicine practice has partnered with Plant-Based Telehealth, and we offer lifestyle medicine consultations. So you'll be able to see me one-on-one, and I can go over your health history and seeing what we can do to fill in the gaps. We can talk about your physical health, anything from food to lifestyle to diet to setting up your kitchen to cooking preparation to grocery shopping to your mental health. I think it's important that we build our emotional resilience to talking about your sleep and how to stay hydrated and what are the best medicines if necessary, what are the best supplementations if necessary. And we do all this in a very concise manner, and it's a conversation. I take the time out to listen. I take the time out to really understand you from the ground up and to look at all aspects of your physical, emotional, and mental health. And please, drop me a line, schedule an appointment if you want to see me one-on-one. And I am very, very looking forward to learning more about you. And again, thank you so much for visiting here at the Chef Doc.
For the provider, I think it just creates exhaustion, burnout, feeling like you're walking into each room with so many obstacles that it's impossible because your goals are to fix things. And God, that is exhausting because it's impossible. These are human beings. We're human beings, right? We're not to be just sort of tinkered with and fixed. So that's one thing. When that load is dropped, it makes practicing just so much easier.
Mm-hmm.
Oh, such a relief to go into a room like this instead of like this,
Yeah.
Oh, okay. So that's one thing. On the other side of the fence is our clients and patients, which, if you're walking into a room as a patient and the person who's coming in and talking to you does not have the insight into your life that maybe you need, you're not getting what you need. You're coming in and AT Still. Okay, right?
Give it to me.
Okay, AT Still, the king of osteopathy, the founder. He said, when you're working on a machine, you need to be a mechanic, not a window washer. Right? So if we're not understanding how everything works together, how trauma can inform people's behavior, the way they see themselves, the way they may choose to have relationships, jobs, how they treat their children, how they treat their bodies, what kind of sleep they might have, or just it informs everything. If you have unexamined trauma and no one is noticing, including the patient, including the provider, the patient walks out with a lot of things that could have been recognized, and instead understands themselves in terms of tiny labels, potential for what kind of medications could be used, and so small, rather than this greater view of what could be done.
Yeah. How much time do you have with a patient in your practice?
If you look at the schedule, patients are scheduled every 15 minutes.
Okay.
Now, to my detriment, or, sort of depends on how you look at it, I ignore those numbers and give the person in front of me whatever they are really needing and what they're requesting. So sometimes that means 30 seconds, of I need this. one thing, sign this form. And I'm not going to turn this visit into something that they don't want. Whereas maybe somebody's coming in and they're fatigued and they're depressed and they have pain. They don't know why. That's going to be a lot longer, and it should be. So
I bring this up because within our current, healthcare model, it doesn't most of the time, 99.9% of the time, it doesn't allow for, cases like that, right? And what's great about what you do is that, when you say trauma informed, what I get from that, and we'll go more into that, in a bit, is that you are already putting out the intention. You already put out, I guess, the disclaimer, as you will, that we're being mindful if that someone does come in with something, with a past or currently present traumatic experience, that you already have the awareness, the mindfulness of sitting with a patient and needing to take them wherever they need to go, because that's what's needed for them. And that in that current, space and time, whatever the patient needs, we're fully equipped to help navigate, hopefully I convey that picture, correct.
Yeah. Boy, there's so many moving pieces to seeing a patient or client, scheduling them, making sure that everybody has enough time, and the logistics can be dizzying. And I try to just give the best care I can at each moment. And when I have a new patient, I usually remind them, bring a book, because if you're scheduled later in the session, it's you just may be waiting a while, but hopefully it'll be adequate care.
Yeah, exactly. I think not necessarily there needs to be a quantification of, how much minutes or how many minutes that someone would need, but it's really the intent, and for you to be fully present in that same room with them, to allow them, to feel heard and recognized and acknowledged that, I hear you, I see you, that you've gone through something, really horrible, and wherever we need to go, that I'm here for you. Sometimes, if you can correct me if I'm wrong, that's all the patient, needs in the first go around. And then hopefully that opens up enough space for them to continue, with you.
So many studies about what do patients really want from their providers. And the ones that I've reviewed, it comes down to listening. And I think what I'm hearing when I see listening is bringing our whole selves, really deeply listening and hearing, and being able to filter that information through so much knowledge that hopefully we've gotten by the time we're listening to someone explain.
You're like, right now, you're like, oh my God, this question. It's like we go for hours. But I know what you're saying is, but I think that's one of the great skill sets of an osteopathic physician, and just being human. And, I don't care who you are. Being human is traumatic. Right. Being human is, there's so many different forms of suffering and different layers of suffering, and it's bringing that experience into the work that you do is incredible. But yes, it's a lot of filtering. It's kind of like, a colander, right? Or a strainer. And you're like, oh my God, there's so much crap. And then at the bottom, you're like, okay, I see this drop down, this drop down, this drop down. Let me put this dish over here. It just can't kind of capture it all. But you can tell I love food analogies. But it's really about the skill set of integrating it, right? And, distilling all that. And then hopefully taking that big ball of wax, and then piece by piece, helping them to kind of reintegrate to themselves, back to themselves, essentially.
Yeah, being able to see a large picture and see things through a reductionist sort of lens, and then sort of integrate a person in our minds is so powerful. I think it goes for so many types of work.
Yeah.
You know, if you're a coffee connoisseur, right? You know, you learn about the people who grew the coffee, and you learn about the soil, and you learn about transportation, and you learn about how to enjoy
the miles
coffee
and the roasting and you know.
Yes. If you just went to a coffee shop, you knew nothing else, and you taste coffee, it's a totally different experience than knowing deeper levels of what you're experiencing.
Mm-hmm. For sure. Mm-hmm. And I can totally relate to that because I went to a coffee farm in Costa Rica, and you know, they were able to show me how they grew, you know, the plants, how they roasted it, and different types of blends to, you know, I even planted, I have to call them up actually. They planted, you know, my plant. They're like, yeah, well, we'll email you know, see how much it's grown. And it's the same thing with ourselves, taking, you know, that growing process, taking from that point A to point, you know, A as in growing the seed and the plant to, you know, B, the coffee in your cup. An analogy would be, you know, that self-examination, you know, taking it back to the roots of where it all started. And then how does that lead to the person that's sitting in front of you, right? And be able to...
Yes.
Right?
Yes. I'm loving this coffee bean analogy. You're giving me goosebumps. I'm like... Ideas for the next book, The Coffee Situation. Yes, very good.
Yeah, so, all right. So the next question is, and I'm going to love that, I love this, is for those that are healthcare providers out there, as well as people that want to learn more, is what is trauma-informed care? All right, how would you define that? And then I would love for you to, let's start with that. What is trauma-informed care? Because that's a huge bulk of what you do, what you've informed us in your book. Let's start with there. How would you bring people up to speed with that?
An interaction might look just like any other interaction. So it's not always visible, trauma-informed care. It's having another level of understanding people and what happens after somebody gets traumatized, and that those are very definable, sometimes predictable syndromes to be able to see. And once you know that, you can infer how this person probably would be most comfortable being treated. And so it's trauma-informed care. I like how it's worded because it's being informed before you have an interaction with someone. Mm-hmm. So knowing about trauma in general and what it might, how those sequelae may surface, what that might look like in a patient.
Mm-hmm. Yeah, so sequelae is a nerdy, word saying the ripple effect and the things that come out, from said pebble dropped.
Yes. Very good.
So I think that's also great because even if you had a patient that you did not have an idea, they came in for a different reason. The reason for visit was different, but it leads to something else that, alludes you to say like, hey, have you ever experienced X, Y, and Z? Or, do you know of someone that experienced X, Y, and Z? Or how does your current symptoms or current concerns relate to that, right? So in a way, because you've already built up, having that experience and built up that skill set, so you'll be prepared even for like, let's just say a healthcare provider that isn't quote unquote trauma informed. I don't know if that's the best way of saying it, won't be as prepared. Would you say that as well?
This is an area that means a lot to me because there's sort of a movement toward expanding trauma-informed care, which awesome, if it's done well. Because if you can imagine, let's just make it very physical. Okay, somebody comes in and they have this massive gash up and down their arm. And they walk in and let's say they are not even aware of this thing that's sticking out of their arm. Okay?
It's like, wow! It's like, don't you see that?
Right. So it's important to call attention to it, but in such a way. And it's important to anesthetize, clean it in such a way, repair it in such a way. It's not sort of, oh my God, look at everybody, this guy's got this huge thing all over their arm, or let's dig in that. Let's just get in there. It's very nuanced. So on the surface level, it's really simple. Like, okay, I get what trauma is, sure. Or I can, understand what the criteria are for PTSD or complex PTSD. And with practice, a whole world starts opening up into, wow. There are a lot of ways that our clinic, for example, could be hurting people without even knowing it.
Right. Or just patients just being brushed, along. And, if I were to place myself, in a patient's shoes, maybe they're just like at the tip of wanting to share. And because the opposite provider was not trauma informed or wasn't putting it in their forefront, they would have missed it. You know what I'm saying?
Definitely. I like this other analogy too, which I give a lot. Yes. When I am doing OMT, in the middle of doing OMT, right? I have my hands on someone's torso, or I have my hands on someone's arm, and I'm gently, usually doing MFR, myofascial release, very gentle. Hardly can tell anybody anything's happening if you're just watching the event.
Yes.
Right?
Yes.
You don't even know what's going on. So
if you've never seen OMT, you might, think of it as just watching grass grow.
There we go.
It's sometimes not much is happening.
Right.
It's not like a Michael Bay production. It's not. But
sometimes these incredible things are happening that an observer might not notice, and it's about the grounding of the professional. It's about the mindful attention. It's about those hundreds of hours of experience that we have knowing and being able to predict what types of tissue feel what types of ways and how something's going to respond. Being able to get the rapport with the tissue with our hands before we start working on someone.
I like that. The rapport with, I like that. Rapport with the tissue with your hands. Okay.
Yeah, like maybe someone who's a cat person versus someone who's not a cat person petting a cat.
Yeah.
Maybe they seem to approach it the same way, but their intention and awareness is going to cause totally different reactions in that cat.
Oh, yeah.
Right? And it doesn't even take a word.
It really doesn't. Oh, man. Okay, so from that, from your experience, you have created an acronym. It's called SWAPT. I would love for you to share what that is and what it's for.
Sure. The SWAPT acronym is based on the CDC's definition of what trauma-informed care really is, which, theirs is, I think, maybe 6-7 different components of making sure that your clinic, your behavior, the staff members are trauma-informed and they're behaving as such. So these are things that are based in awareness and also based in behavior. So SWAPT, so S is for safety. So the first thing making sure that when a patient or client is walking through the door, they feel safe. And that seems simple, but is not. And sometimes takes practice with working with lots of people of different ages, abilities, backgrounds, coming through your practice and giving feedback about whether they feel safe, when they feel a little anxious. Maybe the staff doesn't represent the clientele. Maybe they, who knows? There's so many different routes.
Right, because a person might feel stressed or anxious, and it's different, for in different instances for different people. So to be able to account for all that's challenging. Like, what would be, I guess, a natural question is, what would be a good example of not feeling safe in a particular office?
Not feeling safe. Maybe the lobby is really, really loud. And maybe the seating arrangement is such that everybody is facing each other. What about folks who
don't want to see you?
Yeah, maybe that makes people feel uncomfortable.
Yeah.
So it's not only, it leads into other things, not only about being trauma informed, but just being like person informed, which leads straight into the W, which is welcoming. So making sure that folks feel welcomed. So a really kind of basic example is having diversity, equity, and inclusion trainings, and including a little rainbow sticker, at least on the front of a building. Right away, me as a queer, non-binary person, I feel just sort of this, okay, at least somebody knew enough to stick this sticker on the building to give a marker that I'm welcome here. It's a very tiny example, but that's the W, is feeling welcomed. Let's say somebody comes in who's a refugee, who is not an English speaker. How is that person experiencing coming into the office? Being a refugee means usually having been traumatized in some way already. So making sure that they're not waiting in the lobby forever, feeling anxious more and more, making sure that they can speak in their own native language from the moment they come into the door. It's really kind of a fun game, learning how to...
It's like a puzzle, because you have so many different pieces that's coming through your door, and you're like, oh man, how do we make this piece fit with this piece, and making sure that everyone is happy? I mean, that's a huge challenge on itself. Yeah.
There's another group that we've been focusing on more, and that is being weight inclusive. And so our original office had two scales. One was a standard scale that you would think of. A patient comes in and stands on it. It had a weight limit of 300 pounds. And so folks who were over 300 pounds or who are coming in a wheelchair are immediately othered and immediately do not feel welcome, and had to be put in a different area and use a different scale, and so they're already sort of feeling unwelcome. So the E is for education and empowerment. And this is where it really starts to get truly trauma informed and not just every kind of person informed. So when someone is traumatized, generally one of the hallmarks is feeling powerless and feeling a certain amount of their autonomy has been removed, revoked, feeling that they don't have a voice, that it's not safe to have a voice. And so E is mostly for empowerment. The patients and clients feel that they can give feedback. They feel that they can sort of educate and empower themselves and are not just at the whim of whatever provider is giving them advice. but they're really able to start taking control of their own lives, giving feedback to us as equals, working in as a team, basically, instead of just a kind of subordinate, I guess is the word I want to use. Yeah.
Yeah, because in your book you describe key players in terms of, you know, a support team, and then you talked about therapy, and then you've talked about so many different types of groups. What would you say, because it's such to me, trauma-informed care requires, it's almost necessary to have so many key players to help, you know, offer different ways of supporting that, you know, said person or patient. What would you say would be the necessary key players? So let's just say you have a healthcare provider that's listening in and wanting to become more trauma-informed. Which key role players would they need to either refer to or to bring in to make it more inclusive?
To me, it's more about education and connection. So let's say that there's a provider who works completely by themselves. They are the front desk. They are providing concierge medicine to 5 or 10 clients, and that's how they're getting paid. And they're working all on their own. It's still possible for them to be an appropriate trauma-informed provider. What they need is connections to the community. So having connections and knowing where they can depend on referrals. So to be really specific, that's going to require a therapist, unless that provider is actually a therapist too.
Yeah.
Which maybe sometimes we think we are, but not necessarily.
Yeah.
So having a mental health support team member is critical, especially for family medicine, when people are coming in telling us they don't feel right for whatever reason. And so often there's a neuropsychosocial component to this that needs to be supported by a mental health professional. And then building other roads to whatever the community has. So the social work team, the folks who can provide food, housing. Our office, I think we are really nailing it.
Yeah.
So what is your
we
office? We have such opportunity as a federal qualified health center that we have a huge multidisciplinary team within our 4 walls. We have dental, we have therapists, we have people who draw blood, we have diabetes educators, we have, did I say therapists?
Yes.
Yeah.
That was the first one.
Say it again.
we can't not emphasize that.
We have psychiatry backup. We have a whole medical records team. We have a referrals specialist. And I would say she is probably one of the most key players in our trauma-informed approach. Because if I place a referral to a cardiologist for someone who feels unempowered, what are the chances that this is actually going to get accomplished? Who's following up on that referral? Making sure that there's a workflow in place to assist a patient or client in actually getting the care that they need through advocacy until they feel they have their own empowered voice is crucial. So that's how we make sure that patients get the other types of care that they need as a referrals coordinator. Yeah,
it spells out how nuanced and meticulous that you had to, go through. Because, being in the shoes of the patient, you have to think about all the different steps. I love the fact that you brought it from the front door. It's like just when you open the door, how am I going to feel? How am I going to, feel accommodated or welcomed? Just even to the details of where do I sit, and how are besides people, of how they would address you, and things like that. So yes, I'm loving this. So my last question, last but not least, is what kind of key takeaways would you want? I divided this into like three sets of people. What are the key takeaways would you want a healthcare provider to have, having read, your book, having, take away from this session, a healthcare provider to take away, a parent of an abuse survivor, and ultimately, the survivor themselves? What kind of key takeaways would you want them if you had, a microphone, if you're on the intercom, you're on the PA system, what would you want them to hear, from you, just key takeaways for those three parties?
I would say if you're already doing work such as work on racism, let's compare it to this. How much education do you need to be an anti-racist? A lot. I mean, it takes a lot of education to approach each person that you interact with respect and recognize your own biases and boundaries and blind spots. And to be able to think before you speak, even with that much education. It takes so much work, really, to educate yourself. So that's probably number one, is do the work of educating yourselves about what trauma is, what it looks like, and do a little bit of introspective work to see what types of trauma you may have experienced and just don't want to think about when you're ready, so that it can open up your world and make things easier for you.
For sure.
Yeah, education. That's
for all three
one.
parties.
All three parties. Yeah. All three parties. Because having someone come to you and say something vulnerable is a crucial moment. You have the capacity to help someone or to re-traumatize someone, to close their doors of safety for years if you say the wrong thing. Yeah. And so that's part of why it's so important.
Okay.
Okay.
Frances, thank you so much for sharing your story. Obviously, we didn't, I don't want to, because I want people to get this and read it. Thank you so much for just showing up, being Frances. I greatly admire and respect you, and have so much love for you, just showing up the way you do. And I hope that, through your work, whether it's a patient or they've, heard you speak or watch you from this episode, or, read about your story, they can get, the next steps in terms of educating themselves, in terms of reaching out, in terms of offering support or getting support. And as a healthcare provider, again, we sign up to be eternal, lifelong learners. And I think this is such a is such a huge part in society that's been kind of similar to using racism as an analogy, that's been under, the rug, and it needs to continuously be brought out. And, we need to continue to educate ourselves, more and more. So, thank you so much. I have so much respect for you. And for people that want to learn more, where can they get their book? Where can they come see you as a patient? How do they reach you?
Great. You can go to francissouthwick.com. That is my website. I practice in California's Central Valley here at a federal qualified health center. So you can find me if you Google me. My pleasure. Thank you so much, Colin, for making me cry.
No, that wasn't my intent.
I know, but it was a beautiful experience. So thank you for having me.
Thank you so much. I appreciate it. Guys, thank you so much for watching another episode of Thrive Podcast. If you enjoyed this, please hit the like button, subscribe, and if you feel like someone else can benefit from this, please let them know. And until then, we will see you on the next episode. Please say goodbye to Dr. Francis Southwick. Hey guys, thank you so much for watching that episode. We hope that you enjoyed it. If you like this, please like, follow, and subscribe. And please follow us for the latest updates for this season 5. And if you feel that this was a benefit for someone else, please let them know. And please follow us on Apple Podcasts, Spotify Podcasts, and YouTube. And thank you so much again. And we will see you on the next one.